If you wouldn't mind moving towards your seats, we'll finish the last section. I'm Paul Pockris from Scripps. I'm going to introduce the last two speakers. We're going to have a panel. If you leave early, just remember, in order to get CME credit, you have to go to the online site right here and fill out the questionnaire form in order to get the CME credit. So we're going to wrap up this morning with hepatocellular carcinoma and end-stage liver disease. We're delighted this morning to have Dr. Catherine Frenette, or Carrie Frenette, from our own center, Scripps, who's really built a center of excellence around hepatocellular carcinoma, and she's becoming nationally known in this topic. And she's going to update us on all the abstracts from AASLD. Carrie.
Well, thank you, everyone. We're in the home stretch here. I found it to be difficult to put this talk together because I had so many that I thought were really good abstracts. And so I started with 120 slides. I'm down to 106. We have 30 minutes, right? No, okay. I know that Amit Singhal gave you an amazing talk yesterday, and Paul had said, yeah, he basically said there's 6 drugs and we don't know what order to use them in, and can you help? And I said no. So I'm really not going to spend a lot of time on the new systemic therapies because you had that discussion, and I also know that we don't know which order to put them in, and I wanted to point out some of the more sort of on the earlier side of things. So this is what I'm going to go through. There's a little bit about changing epidemiology, prevention, who and how to screen, a little bit of new surgical data, local regional therapy, and then just a couple slides on systemic, okay? So first, just a few words about the changing epidemiology. So this is really important for all of us to know because that way we'll know who we have to worry about with cancer and what's happening. And you've seen the data and the slides that tell you that HCC incidence has been skyrocketing from 1974 up to 2013, which you can see right here. So then really in 2013 to 2015, for the first time, we're seeing a stabilization of both HCC incidence and mortality, incidence-based mortality. So we really are starting to see this level off, probably because we're treating more hepatitis C, but it is sort of heartening to see that we are seeing that. And we are also seeing an increase in improvement in 5-year survival rates. So in 74, it was 3.7%. We're up to 21% in 2010, which is really because mostly of that localized disease. 5 years from now, it'll probably be even better. So just let you know that we are making progress. In Medicare patients, this was an abstract that specifically looked at patients with Medicare and what was the resource utilization and what was the causes. And really what we're seeing in the patient population over this age of 65, you can see we're just seeing an increase in fatty liver as well as hepatitis C related HCC. So again, this is just a plea to all of you, and I know you all know this, but please don't forget to screen the hep C people after you cure them because they still will get cancer. Alcohol and hep B were actually relatively stable, but the predictors of the 1-year mortality in these patients, the best predictors actually were being a man, sorry men, having cirrhosis, which you would expect, but then fatty liver actually had almost 2 times the risk of dying in 1 year as other causes of HCC in the Medicare population. So again, just sort of pointing out that fatty liver is a very important cause of HCC, and we really have to make sure that we're staging those patients and screening them appropriately, which we're figuring out how to do. So how do we prevent cancer, liver cancer? So I get this question a lot from my patients. I talk to them about screening for cancer, and they say, well, what can I do to prevent it? Because that's what they want to know. They don't want to get cancer, of course. And we know that treating their underlying hepatitis or stopping alcohol, that helps. So those are sort of the easy ones. But what else is out there? So there was a really interesting study, couple abstracts that came out of the same patient population of patients with chronic hepatitis B and diabetes. so over 29,000 patients. And they looked at these patients from 2000 to 2017. A little over 9% of them developed cancer after a median follow-up of 7 years. And then what they did is they said, well, what are we actually treating their diabetes with? And is this making a difference? So what they actually found is that when they used the TZDs, they had a 50% reduction on the multivariate analysis in HCC development. So really they realized that at least in this patient population with hepatitis B, possibly TZD risk treatment of their diabetes may be helpful in terms of getting their HCC risk lower. Also, same population, they looked at glycemic control, and again, we know that diabetes increases the risk of cancer, but in this patient population, what they found, this is hemoglobin A1C down here. The lowest risk was actually right around a hemoglobin A1C between 7 and 7.5, and then the worse that your diabetes was controlled, the higher the risk was. But a little surprisingly, it's a bit of a J-shaped curve where if they were too controlled, they actually also had an increased risk. Now this, to me, may be because as they get more advanced liver disease, the diabetes generally gets easier to control, and you see hemoglobin A1Cs dropping. So this might be a sign of the more advanced liver disease patients getting HCC, but definitely controlling diabetes is an important risk adjustment that the patients can do. So then aspirin, use, actually this came out as well. So this was actually a study looking at the Nurses' Health Study of 133,000 patients. And they looked at aspirin use for primary HCC prevention, looking at both doses and duration. Also looked at the patient population from the Health Professionals Follow-Up Study to see if aspirin use could potentially decrease the chance of getting HCC. What they found is that, yes, aspirin actually does decrease the risk. So this is duration of use, so looking at, this is never using aspirin. So the longer that the patients used aspirin, up to over 10 years of risk, there was a 50% reduction in HCC development. The other thing that they saw is that if they discontinued aspirin, the longer that they were off of it, the higher the risk was. So once you're off of aspirin for, I believe this was 8 years, the risk went back up to double. So it's sort of a dose response where the longer you're on it, the more protection that you're gonna have. So aspirin may actually be beneficial in terms of decreasing the risk of HCC. And then otherwise, we also know and have seen data on population-based studies that statins may decrease the risk, but the question that I always get is, well, which statin should it be? So this was actually looking at the type of statin. So if you remember way back to pharmacology in med school, there's lipophilic statins and hydrophilic statins. So the lipophilic statins are atorvastatin, lovastatin, and simvastatin, and the hydrophilics are the pravastatin, rosuvastatin, and fluvastatin. So this was looking at the Swedish registry and looking at the different statin use and the risk of HCC development and death in patients with both Hep B or Hep C. And what they found is that if they looked at the lipophilic statins, so again, atorvastatin, lovastatin, simvastatin, if the patients were on it, they had calculated this cumulative defined daily dose. These statins actually decrease the incidence of HCC over a 10-year time period. However, the hydrophilic statins had no effect. So if patients really are interested in thinking about a statin for HCC risk protection, you want to pick a lipophilic statin for that reason. And then this was not at AASLD, but I always like to talk about coffee, okay? So this is actually an ad that was put out on Facebook from the University of Chicago that coffee is beneficial to patients in fatty liver disease, and there's actually been lots of different studies looking at coffee and protection against alcoholic liver disease, lower risk of HCC, lower risk of fibrosis, and it is also a dose-response curve. So the more coffee you drink, the better. So I have right here my 20 ounce. This is my third fill up, okay? So drink up. It does not have to be caffeinated. Decaf counts. The reason that I'm bringing this up here is just to make sure everyone is aware that the new HCC EASL guidelines from this year specifically recommend that any patient with chronic liver disease should be encouraged to drink coffee. So I do this. I'm waiting for Starbucks to sponsor me, so if anybody has an in, please let me know. But coffee should be recommended because of the decreased risk of HCC. Okay, so that's the prevention part. What about screening? Who should we be screening? So it was really talking about who gets cancer, and there was a couple really good studies on Hep B specifically. So this was looking at the need for HCC surveillance after 5 years of therapy in patients with chronic hepatitis B. So this was Caucasians, who 73% of them had chronic Hep B with or without cirrhosis in the Page B study. And they looked at what happens to them after 5 years, okay? So baseline cirrhosis was in 26%, 70% of them were men, and they had about 8 years follow-up. And what they saw was that in patients who have been on therapy for 5 years, HCC in this cohort exclusively developed in patients over the age of 50. No one under the age of 50 in this cohort got cancer. Now, not changing the guidelines for recommendations, but just saying that age does matter. The other thing that's important is we all are using elastography now, and we know that hepatitis B treatment reverses cirrhosis with time. However, the patients who had cirrhosis at baseline that had reversal in the blue bar, or the patients that had cirrhosis at baseline and no reversal, had exactly the same risk of development of cancer. So if your Hep B person reverses their cirrhosis, that's great, but it is not a way to relax about cancer, okay? The other thing that's helpful is looking actually at ALT levels in patients who are on therapy. Again, the Page B cohort, same patient population, and they looked at actually whether ALT levels can affect the incidence of cancer when they're on therapy. And what they found is if you look at the ALT level in these patients at 1 year on treatment, if their ALT is above the upper limit of normal, which they use the EASL upper limit, which is 40, they had a higher risk of developing liver cancer. So it was about 10% at 5 years. So this effect was particularly seen in patients who had cirrhosis at baseline, but any abnormal ALT at 1 year portends an increased risk of development of cancer, likely because of the ongoing inflammation that we're seeing with abnormal ALTs. And then the other thing that you can be used in Hep B patients to predict risk was the FIB4. So the FIB4, to remind you, is just an easy calculator, age times AST over platelets times the square root of ALT. I don't do this in my head. I go to Google, I type FIB4 calculator, and it's the first link that pops up. But looking at the FIB4, which is a non-invasive marker of fibrosis at 1 year post-treatment, if your FIB4 normalizes, gets to less than 1.29, you have a lower risk of HCC than if it stays elevated. So this is something else that you can use to give you an idea of what the probability of your patient with Hep B is and with getting cancer. And then this one was a patient study that looked actually at the VA. So I included this because it's a different patient population, not the Hep B, and it was 116,000 VA patients who had cirrhosis, and they had about 10,000 new cases over an average median follow-up of 4.2 years. Hepatitis C had a 3 times higher risk than alcohol, NAFLD, or other causes. No surprise there. We were seeing a higher HCC incidence and cirrhosis that was diagnosed between 2007 and 2014 compared to the earlier time point. And then also the independent risk factors for HCC development was age, male sex, Hispanic ethnicity, an AFP elevation, but also an ALK phos elevation, low serum albumin platelet count, so signs of more advanced liver disease. And then diabetes, the effect of diabetes on HCC development in this population, it was only increased in patients who were diabetic and had cirrhosis from either alcohol or fatty liver disease. So sort of lets you have an idea of the different risks in your patients with different causes of cirrhosis. So how should we be screening? So that's who. So how should we be screening these patients? So I'm going to include just an abstract from the International Liver Cancer Association meeting from this year. This was in September of this year in London, which was beautiful. And Amit Singhal actually presented this, and he did a meta-analysis looking at ultrasound alone. If you recall, the guidelines say ultrasound with or without alpha-fetoprotein, and there's always a discussion of whether or not we use alpha-fetoprotein. So this was ultrasound alone, and what he found was in this meta-analysis, the pooled sensitivity was 0.47 for ultrasound alone. So pretty awful. So really not very, it's sort of, a little bit of flipping a coin. When in the meta-analysis he actually added alpha-fetoprotein, the ultrasound went up to about 63%. So definitely better, about 20% higher if you add AFP. And the best benefit was seen in studies in the United States, where we know that patients have more cirrhosis, more difficult to get a good ultrasound, more obesity, more difficult to get a good ultrasound. So this was data that made me more comfortable to say, yes, I should use AFP with my ultrasounds. Now, at AASLD, there were several studies, but I'm including two on how to screen. This one was alternating CT with ultrasound for chronic Hep B patients with cirrhosis. So these are obviously people who are very high risk. And they looked at HCC detection rates with using just ultrasound every 6 months versus alternating a CT with an ultrasound. Their 5-year cumulative HCC risk was about 13.7%, and the alternating CT and ultrasound actually had a 2.5 times more likelihood of catching the cancer when it was in a curable stage, BCLC 0 or A. So again, this was in specifically Hep B cirrhosis patients, but suggesting that maybe throwing in some cross-sectional imaging every once in a while might be useful. The other thing was actually looking at the cost effectiveness of MRI. So I thought this was really interesting because we all know that MRI is crazy expensive, and that's why we don't use it. And what they actually looked at was, and they looked at the numbers, this was out of some researchers in Korea, but they used US numbers for getting the cost. And they actually found that you look at the semi-annual ultrasound in the patients that are high risk for HCC, so those Hep B cirrhosis patients who are diabetic and men, they actually saw an incremental cost-effective ratio that was below the cost of the effective threshold of $50,000 quality of life years, which is the level that is sent to be cost-effective. So when your incidence is over 1.89% per year, so your higher level risk patients, especially in your patients where your HCC incidence is more than 5% per year, so you remember Hep B cirrhosis, it's about 8% per year. And then it was only $10,900 for a quality of life year saved to use MRI rather than ultrasound for screening. Okay, so what about some more surgical therapies? So looking at transient elastography prior to resection or transplant. So there was 2 abstracts on this where they actually looked at transient elastography. So I have a little typo there, I'm sorry. So 267 patients who underwent resection had shear wave velocities before surgery. And what they found in that abstract was that liver stiffness was the only independent predictor of whether the patient was going to decompensate and develop postoperative ascites. The cutoff for postoperative ascites was 1.79, and I have a table that tells you exactly what that is in FibroScan KPA levels, but it's about a KPA of about 10, 9 to 10. And then another abstract looked at patients that were before resection or transplant and had both liver stiffness as well as CAP scores. Liver stiffness over 30 had a poor prognostic indicator for overall survival with resection. So if you have a very high liver stiffness, then resection may not be a good option for you. If your liver stiffness was over 30, you also had an independent risk factor for dropout off the transplant list. So those are patients you may want to think about other options. And then your liver stiffness over 30 and a CAP score less than 240 in patients with F3 or F4 were predictors for early recurrence of liver cancer. So that's sort of interesting also, that more advanced liver disease, perhaps they may have a higher risk of early recurrence. That may then let us design a study where we're now using postoperative adjuvant therapy to try to decrease that risk. That might be a way that we can figure out the right patients to put in those studies. So something to think about if you're considering a resection of a cancer. And then there was a little bit of data on downstaging of cancer before transplant. So we all are very familiar with the Milan criteria, where you can have 1 lesion up to 5 or up to 3 lesions less than 3. There's also the UNOS downstaging, which has been put into effect a few years ago, where they can be outside of Milan criteria, but within the UCSF criteria, be treated to within Milan and get MELD exception points. And now we're also looking at what's called all-comers protocol. So this is patients who maybe they present very late and they're outside of that downstaging criteria. So your guy that's got 1 lesion that's 9 centimeters, that's outside, but he has a great response to local regional therapy and gets into Milan. That's called an all-comers. Is this something that we should consider for our patients? So When they looked at post-transplant survival, we did see no difference between the patients who were within Milan initially versus that were downstaged but within that UCSF criteria. But the downstage patients did have a lower survival at 3 years, 71%. Now, this is not great when we think about transplant, but when you think about their other options, this is probably better survival than what they would get if they were not offered transplant. So that's something that you could potentially think about for those patients who have a really good response. They also looked at this difference between long wait time regions, short wait time regions, and medium wait time regions. So we also know that here in California, we have a very long wait time, and we are in one of the longest wait times in the US. So we're considered a long wait time region, and sometimes patients go to other areas of the country to get transplanted, to try to get their transplant sooner. And what they actually found was that in Milan criteria, it doesn't make a difference. There's no difference in survival difference by wait time region. However, when patients are downstaged into Milan criteria, their post-transplant survival is actually much better than if they had moved and gone to a short wait time or medium wait time region. And the reason we think this is true is because the long wait time that's over the median was like 12.6 months or something, a little over a year. That gives you an idea of the natural history of that tumor and whether that tumor is really going to be controllable prior to transplant. So that's something to think about when patients are thinking about going to a different region. As you know, UNOS has now put in a mandatory 6-month wait time prior to getting MELD exception, which has mostly affected the short wait time regions because they were transplanting much shorter than that, and that actually has already made a difference in terms of survival of cancer and recurrence post-transplant. And then this is the all-comers protocol, all-comers where they're outside of even downstaging, and again, by wait region. So again, long wait time region was best for post-transplant survival because again, these patients now are being able to be controlled for longer before. And you see a little drop-off in the short and medium wait times. When you looked at the predictors of post-transplant death among patients that were ever downstaged, the biggest predictor was actually being in a medium or short wait time region where the hazard ratio was 3 times higher, but also an AFP over 100 at time of transplant also had a higher rate of post-transplant recurrence and death. So we really want to see that AFP response, and if their AFP was elevated initially, we want to see it come down before we transplant them to know that they're going to do well. So then some new data in local regional therapy. There was a whole bunch of different stuff, and I knew that Amit was going through a whole bunch of stuff yesterday, so I decided not to bore you. I will tell you that there was several studies coming out combining local regional therapy with systemic therapy. There was also studies looking at combination of TACE-RFA, which we've done. There's also studies looking at combination of TACE with SBRT. We're using more and more external beam radiation for treatment of liver cancer as the radiologists are getting better at aiming their radiation, okay? So more data coming up but they were all very small single center studies. One of the things that I thought was important for everyone to be aware of, this was a study where they actually looked at patients who were getting TACE procedures and said, well, why are they not stopping the discontinuing further TACE, and what happens to them based on why they discontinue TACE? So it's a smallish study. It's 192 patients. Patients received anywhere from 1 to 7 TACE procedures with a median of 2. When they looked at the reasons for discontinuing TACE, 74% of them were because the tumor was progressing, and 19% was because of liver dysfunction. So their Child-Pugh went above B7, so B8 or above, now too sick to get further local regional therapy. The problem and the reason that this is important is because patients who discontinue due to liver dysfunction, only 8% of those patients were actually able to recover well enough to receive any second-line therapy, including systemic therapies. So the patients that are having a lot of liver dysfunction with their TACE, if they keep getting TACEd, they potentially are being prevented to benefit from all of these new drugs that we have. So you really want to be careful when you're ordering more local regional therapy that you're not doing so much that you're beating up this liver and now they're going to be too sick to get systemic therapy. The patients who were able to receive second-line therapy had a survival of 21 months versus 12 months in everyone else, so this does affect survival. So the trick is trying to figure out when is the right time to stop doing a TACE, but the one thing to really think about is how did their liver tolerate the one that you just did, okay? If you're seeing a little dysfunction, it's probably not the time to go on to your next TACE procedure. And then just a little bit about systemic treatment. I know that Dr. Singal talked to you about the nivolumab in the Child-Pugh, but I'm bringing it up again because I think it's really important. So we all know nivolumab is immunotherapy. We all know immunotherapy is one of the things that we're discussing right now. And this was really the first study of looking at patients with Child-Pugh B cirrhosis getting immunotherapy and what happens to them, okay? So these patients, the important parts with the Child-Pugh B, they were B7 or B8, so the earlier Child-Pugh B, they either had to have no ascites or mild ascites. These are not the people who are coming in getting tapped every week that were included in this study. They were not enabled to be enrolled if they had a history of encephalopathy within 6 months of screening, history of renal failure, or a paracentesis within 3 months. So again, Child B, but not terrible Child B, okay? One thing that's important to know is that the Child-Pugh B patients did have a lower response rate. So we all know the response rate for immunotherapy overall is about 20%. Child-Pugh B patients had about half that response rate. Not clear why, if their immune system is, just not strong enough to respond or whatever, but you want to realize to educate your Child-Pugh B patients that they may not respond as well as what they expect. Disease control rate was a little lower, and there was a little more just stable disease as opposed to shrinkage. However, the important piece that I want to point out is that of the 5 patients that responded, 4 of those had recovery of their liver function. They went from a Child-Pugh B to a Child-Pugh A, okay? So it took about 3 months to see them respond, and the duration of response was a little shorter in the Child-Pugh B patients, so 9.9 months versus 12.4 months in everyone else. However, if your patient has a mild decompensation and they're able to get immunotherapy, if they are in the lucky 10%, you may actually have some improvement of their liver function when they respond. So I thought that was really important to realize. I think I took out the safety slides for time, but basically the Child-Pugh B patients did not have any increased risk of serious adverse events, liver dysfunction, hospitalizations, hepatic adverse events, colitis adverse events, anything. So safety was very good in your Child-Pugh B patient. So conclusions from all these abstracts. So HCC incidence and mortality is stabilizing for the first time in over 40 years. So we're finally starting to make some progress. We are, however, seeing an increase in NAFLD as a cause and cost of care in patients with HCC in the Medicare population. Things to think about to decrease the risk of HCC, TZDs, better glycemic control, maybe some aspirin, your lipophilic statins, and please don't forget to recommend that coffee. In your chronic Hep B patients, if they're on therapy for more than 5 years, the risk of HCC is highest in people over the age of 50, and do not stop screening just because you've reversed their cirrhosis on elastography. That does not protect them. If their ALT is still elevated a year, the risk is increased, and you can also use that FIB4 that I showed you to predict increased risk. Screening with combination therapy is better than ultrasound alone, and we may get more data showing that MRI or alternating ultrasound and CT may be cost-effective in those high-risk groups. You can use elastography before your surgical treatment to think about what is this patient's risk with surgery. We can downstage people to transplant, and that can offer a survival advantage, but that mandatory wait time and the AFP at time of transplant are important predictors of recurrence. Don't taste people to death, okay? Stop your tasting before your liver gets starts having dysfunction, and then nivolumab can be safe and effective in some people with Child-Pugh B with some recompensation. And that's what I learned at AASLD. Thank you.